Just going to explain how we're going to do this. We have about maybe 20 or 30 questions here. Some of the questions overlap. So if your question is not exactly answered on an individual basis, please realize that for the sake of time, we're slipping things together there. Some of the questions are basically imaging, nuclear medicine, type of and technical questions. They'll come in the second part, and some of them cross over. So we'll tear the thing apart, and you'll maybe get the answer one way or get the other, depending on whether people pass on it. I'll be passing the questions to Dr. Wong, and he'll be asking the panel. That way, hopefully, we won't have too much interesting discussion, i.e. argument. So I'll ask Ralph to come up, and he'll kick off.
Thanks, Robert. So my name is Ralph Wong. I'm a medical oncologist in Winnipeg, and I've been asked to moderate the first part of the session. And we have thank you for all of the questions. We have quite a few, so hopefully we'll get through them all. So the first two questions, can Mets metastasize even when the primary is 100% removed? Sorry, can Mets, usually that's the last thing my patients tell me, I can't hear you. Can Mets metastasize even when 100% of the primary is removed? Do metastatic lesions tend to be more aggressive / proliferative than the primary tumors? An excellent question.
The answer is that nobody knows the answer about Mets metastasizing. There's a lot of work done by a guy named Don Morton, probably 30 to 40 years ago, where he looked at the incidence of metastasis downstream from known metastasis in lung cancer. And he thought that, yes, metastatic lesions could spawn metastatic lesions. And it sort of makes sense. If you believe Dr. Folkman, who's the guy who is the father of the angiogenesis theories, that any time you have a blood vessel that's feeding a tumor, whether that's a primary tumor, a metastatic tumor, etc., that the cells in the tumor can actually burrow through the walls of the blood vessel and get in the lumen and take off. So the answer to that, I think, is probably yes. It's very hard to prove unless you had some way of tagging the cells of a primary tumor and tagging the cells of a metastasis so that you look for blue cells downstream or orange cells downstream. You might be able to do it that way. The second part of the question, are metastases more aggressive than primaries? That's what we were talking about yesterday that we're doing in the lab. We're looking at the Ki-67, the chromogranin, the synaptophysin, the CD31, which is a measure of angiogenesis, factor VIII, which is a measure of angiogenesis in primary lymph nodes and in livers. And it's very individual. It's very interesting that not always are metastases more aggressive than primaries. Sometimes primaries, sometimes Mets.
It's if you think about it logically, the body is a hostile place for something to grow where it's not supposed to grow. And for metastasis to grow, it has to bypass a lot of systems and be able to establish itself. And as a general rule, though, I would say that they are more aggressive, as a general rule. The third part of the question, I forgot it was actually down here, and I guess you alluded to it, is should Ki-67 be done on all lesions?
We're certainly doing that on everything we resect now. Even if we resect a right lobe liver met and a left lobe liver met, but it's part of a study that we're doing. So could I recommend that, or would I tell you to go out and get an extra biopsy just so that you could evaluate that? I don't think I would do that.
You're also probably going to know from the pathologist, since we're from the Canadian perspective, we're very short-staffed in that field.
I think I would like to make a comment on Ki-67 and in different places. I think an important thing is to look into the tumor and see if you have hot spots. Because you can have a Ki-67 of about 4 or 5% in most of the areas of a tumor when you stain it. But you can have hot spots up to 10, 15, 20, 25%. And this population of tumor cells are the dangerous ones, because those are the that are prone to metastasize, and you see them later on in lymph nodes and liver metastases.
Also, I'd like to caution people against putting too much faith in the Ki-67 from small biopsy specimens. It's one of the problems is that people hear the Ki-67 is really good, and they insist that they get a number on the Ki-67 from their local oncologist. And it's easy to do the test on fixed pathology slides, but the problem is there's a big sampling error in small biopsies, and sometimes the number can either come out very high or very low, and can sometimes be in conflict with the clinical course of the disease and the natural history and the way the patient's cancer is growing, which I think is far more important in evaluating therapy than a Ki-67 from a tiny biopsy. I think anytime there's a significant resection specimen, whenever possible, I like to see a Ki-67. It's interesting to see it from a biopsy also, but just realize you can't put too much stock in that.
And remember, one of the old adages in pathology land is the amount of knowledge you gain from the tissue is proportional to the amount of meat on glass. So the more of your tumor you put in specimens on slides, the more information you get out. And I think that's one of the things the pathologists year after year have always taught me is you never have too much of a biopsy. You can only have too little tissue for a biopsy.
And those points are very well taken, and certainly that probably would explain why some of our patients with Ki-67s of 3% behave like small cells and others are 20, 30%. I have one patient with a Ki-67 of 30% and not doing anything. And our pathologists are also very good because they tell us that, you know, we've got a fine needle aspirate here. We're not going to get the information that you want.
Dr. Warner had a comment.
Yes, Dr. Warner. Okay, if you come up here and talk, sir.
Here you go, Richard.
Dr. Waltring's comment about the benefits of having a large amount of tissue in biopsy is very well taken, and a very important point is this concept and this actual principle renders the fine needle aspiration biopsy not at all as desirable as a core biopsy. And unfortunately, the FNA, fine needle aspiration biopsy, is used rather widely because it's easier, it's a bit safer, but it isn't nearly as good as a regular core biopsy or, of course, an open biopsy with a real piece of tissue.
Okay. The next question is, what is the status of getting lutetium approved in the U.S.? That's you.
That's me. Dr. Abe Del Pasan in Houston, XL Diagnostics, has an IND that has been submitted to the federal government. They have had the 30-day window response. They have re-responded to that on, I think, 2 or 3 separate occasions. And for those of you who've never dealt with the FDA in the United States, it's a lot like getting a hemorrhoidectomy every morning without anesthesia. Other than that, it's not too bad. Abe still is stymied in getting lutetium-177.
You haven't had to deal with administration every day, do you?
Yeah, I do, unfortunately. But anyhow, it's coming. It's incredibly slow. For now, if you want to get lutetium, you just need to go to Europe. There's just no doubt about it.
Maybe I can also make a comment that Professor Eric Krenning and our group is putting together a file for FDA on the result of lutetium in Europe, and hopefully that will be done early next year. And FDA has required this file, so maybe during next year in some way it can be available in the U.S. at best.
Follow up to that, Gene's comment. There is one legitimate industry that's pursued it, and that's Molecular Insight Pharmaceutical. They bought the license from Novartis that was doing...
Not for lutetium.
I'm sorry.
You're
One
talking
second.
about
I know,
yttrium.
but the yttrium 90 and the lutetium are hopefully in the offing. But Molecular Insight Pharmaceuticals is advancing the Y90 initially through the FDA, and they are starting studies at Sloan Kettering for the dosimetry. And the other company is Covidia and Covidia and Biosynthema are working, I think, via the European connection for the lutetium-177 octreotate as well to submit. So I think Dr. Oberg's comment is very critical in terms of our hope to get lutetium in the United States.
Next question. I cannot stand LAR. Now, I'm not certain what that means, whether it's side effect profile or the way it's given. What are the alternatives? So which one of you would like to talk about somatoline?
Maybe I can do it because we have a long-standing experience of the somatoline in Europe. And sometimes when the patients are saying that they can't stand octreotide LAR, we try to switch them to somatoline autogel, and it's working in many patients. So that is one of the first options. In Europe, we also use interferon, as you have heard from me, so we can sometimes reduce the dose of somatostatin analog by adding the alpha interferon. But usually, many patients are tolerating one or the other of these drugs, so you can try to switch between them.
Sometimes patients find the injection difficult, and especially if they're quite underweight, then the injection site becomes painful, and every 4 weeks you go from one buttock to the other, and both sides of the body become quite painful. And I find that a lot of patients complain about this, and for this reason the somatoline autogel is an easier injection. It's subcutaneous. It's not deep intramuscular, and it's easier to take. And if the patient responds equally well to both, if it's just the physical giving of the injection and receiving of the injection, the autogel can be easier.
Did you want to add any further? Okay.
No, I agree. I think that would be my first choice as well, to use the lanreotide when people have a problem with the depot injections. Just while we're on the subject of the use of octreotide, though, I think it's worth mentioning that there are many physicians who still start patients on sandostatin LAR, octreotide LAR, as the first drug. And if people have a problem tolerating that, they're stuck with this medicine in their body for a month, having continuing side effects that may be hard to control. So I think it's important to do it in the recommended way of starting with small subcutaneous injections, escalate to a full dose, and then give the long-acting dose when you know the person can tolerate it, overlap the short-acting injections for another 2 weeks to maintain a steady-state blood level, and then usually problems can be worked out. The other issue is that it depends on what the tolerance problem is. Is it the sore rear that comes from the injection, in which case somatoline will stop that problem since it's a subcutaneous injection. But what people mean by lack of tolerance in many cases is excessive gas and bloating as a result of steatorrhea from decreased pancreatic enzyme production. And if that's the case, you have to sort of fine-tune the pancreatic enzyme replacement before advancing, because otherwise that same toxicity will be a problem with lanreotide that you're having earlier on with octreotide.
Just to stress 2 points I mentioned 2 days ago in my talk. The first one, I do agree with the fact that in Paris we treated a lot of patients who are resistant to octreotide and who responded to lanreotide. So it could be in a way surprising, but it's the case. And the second is that I think that when you do not have any more solution with somatostatin analogs, maybe you should again consider some kind of new anti-tumor treatment, because it's always a very good symptomatic treatment.
Just to follow up, in terms of the lanreotide in the United States is approved by the FDA for the use of it in acromegalic patients. These are pituitary tumors that make it. It's considered out of indication for the neuroendocrine tumor patients. However, the I think Gene can comment on it better, but I mean, they're virtually identical in action, and ease of use would offer another opportunity for lanreotide depot in those that suffer from the long-term use of octreotide. And again, it's as Dr. Wolin pointed out, I mean, one of the side effects that make it distasteful, but it's the same in both, is the pancreatic insufficiency, which over time, fat studies show that you start to reverse that phenomenon of fat diarrhea, but the pancreatic enzyme replacements can alleviate a lot of diarrhea and gas and flatus that was talked about yesterday.
I guess my only comment would be the people that I've switched over from LAR to somatoline depot have done very well. In the U.S., the good news is when the somatoline depot came out, it was priced identical to the LAR, so that there's not a huge cost differentiation. And so far, we've been very lucky when we had a good case for the asking to switch. We've not had any of the insurance companies, but I think one turn us down, even though it was out of indication.
Just a small comment on the injection technique. What we see on the PET-CT scan in many patients is that the LAR is not intramuscular, but is in the fat tissue. So you see it on the PET-CT scan because it causes a fat necrosis and some FDG uptake you find in the fat tissue. And I think this is a reason why in many patients it doesn't work, because it's not correctly injected. And it also is painful because of this fat necrosis which are caused. And that's also the reason which was just mentioned, that somatolene sometimes works and LAR does not work. I think it's just a technical problem. So what I would strictly recommend is that this is done by experienced people, having a training before how to do the injection. Many patients tell me, when I ask them who did the injection and how it is done, oh, they injected it, shaked it, and then injected. It cannot work this way. It has to stand 10 minutes. You should not shake it. You should be very careful when you draw it from the vial. And there are some technical things which are very important if you inject sandostatin LAR, which are in many cases not regarded.
And from a Canadian perspective, just like in the U.S., it's only approved for acromegaly. And your individual provinces, whether you can access somatoline, I cannot comment. I know in Manitoba we can. Your private insurance companies may pay for it. They may not, depending on your insurance company. So the access to the drug, it is available in Canada, but only for the indication of acromegaly. So whether individual provinces will pay for it if there's intolerance to sandostatin LAR is unknown, and I cannot make a comment about Ontario.
One of the things that we've used to help back up the argument is blood levels of octreotide. I don't know if that's available in Canada anywhere, but in the U.S., if patients, again, like was said, if you're 100 kilos and you have this much fat between the skin and the muscle, a 1.5 inch needle or a 1 1/4 inch needle is not going to get it in the muscle, and it's not going to absorb. So your blood levels are nowhere near what you need. So in those cases, it's another objective criteria you can give to an insurance company to say, here's evidence that this drug's not working, and we'd like to try a different drug.
Okay. So next question, going back to Ki-67, one part of this question I believe may not have been answered, is one, would you recommend routine Ki-67 on all net histologies, not all metastatic lesions? And two, would you expect diagnostic inaccuracy given the low volume of Ki-67 performed? So a two-part question. Who would like to answer that?
I must say that I strongly recommend you to ask your pathologist to get the Ki-67 on all specimens you are providing the pathologist. And actually, we described Ki-67 already in 1986 from our lab, the value of it in neuroendocrine tumors and the impact on survival. And it took 20 years to get it run all over in different countries. So my recommendation is ask your pathologist to run Ki67. The MIB1 antibody is cheap. It can be done on formalin fixed. And so that's my message.
We probably do as many Ki-67s a month as anybody in the United States, and we've taken it out of the hands of our own pathologist. And we send everything to a reference lab. We use Genzyme. There are a number of reference labs that do it. And I think whoever asked the question asked a good question. If you do 100 of these a month, are you better than if you do one a year? And I think the answer is yes.
You have to, I can only speak from the Manitoba perspective, but we've suddenly been getting this blowback from the pathologists. We've been getting this blowback from the pathologists saying, why do you want this? So it can be quite difficult sometimes to persuade our local pathologists to actually do the test. But you're right, it's a fairly straightforward test. Now a question on nutrition and food. In the last session on Saturday, Dr. Woltering presented studies on some expensive compounds, black cherry, sweet tea. Is anyone doing research in this area that you're aware of, or on more commonly available substances that are being studied for general anti-tumor growth, such as turmeric, medicinal mushrooms, etc., and also change in diets like following Dr. Wheel's anti-inflammatory diet? Who would like to tackle that question?
Well, turmeric, we actually have done a lot of work with turmeric. As you know, the active ingredient of turmeric is called curcumin, and turmeric itself is not orally available. So you can eat 26 pounds of turmeric and not get nearly the benefit that you think you are because of the insolubility and the lack of absorption. And it was one of the questions that I was nailed with early on is, do we know the bioavailability of our compounds like Chinese sweet leaf tea and black raspberry and things like that? So the answer is turmeric has an active ingredient. Curcumin is active in our assay, and the trouble is that you can eat a pound of turmeric and not get very much bang for your buck because it's not orally absorbed. There are a lot of, we're part of a screening program for the Louisiana Agriculture Renewable Resource Center that we're screening thousands of compounds a year for Dr. Zhejian Liu. So if you have a favorite compound, we're doing them all blind, so we don't know what they are, and so we can't intercede and throw our own bias in there. We have an ophthalmologist who sent us just a bunch of leaves and said, extract this and tell me if and it's very active, and we don't have clue what it is. So if you have some strange compound you want tested, give me a ring.
Does anyone want to answer the second part of the question about the anti-inflammatory diets or other diets such as the macrobiotic diet, et cetera, or not? Okay. From a diet perspective, I always tell my patients, just eat a common sense diet. Don't go anything wild and crazy. My first job was in Newfoundland, and if you know the Newfoundlanders, they love their meat. And at that time, the macrobiotic diet was very popular, and I still don't know if it's popular. But they cut out so much things they loved, milk, meat, etc. They were miserable as sin. And to make a Newfoundlander miserable as sin, you really have to as we all know. They lost weight. They felt awful. And I said, well, why are you doing this? Well, so there really is no evidence that any of these diets work. And it's just like there's no evidence that high-dose vitamins work. In fact, they may cause harm. So just use common sense. That's all I advise my patients. Now, the next question. Has the incidence, and this is actually a very good question, has the incidence of carcinoid neuroendocrine/neuroendocrine tumors increased in the last decade worldwide? If so, although rare, what might be the cause? Dr. Oberg, I think you've addressed this question in previous talks.
Yeah, I showed this graph in the beginning of this meeting, and it's quite obvious that over the last decades it's a significant increase in the incidence of different neuroendocrine tumors. Actually, all subtypes of neuroendocrine tumors have increased over the years, and it's a more than 200% increase. And The reason for that, that must be several reasons, and one is, of course, the people are more aware about these diseases. The doctors are more trained. They are looking more careful for it. We have better diagnostic methods for this type of tumors during the last years. But I think taking away all these factors, I think there must be another reason, and we don't know exactly. In terms of gastric neuroendocrine tumors, maybe the use of PPIs might play a role in this type of tumor, but that is maybe not true for the other subtypes of neuroendocrine tumors.
Yes, and I just follow up with Dr. Oberg. He's co-editor of a recent text with Irv Modlin, who have started to break it open. They quote, I think, 800% increase in the incidence since 1989 in the United States. And the prevalence, I think James Yao recently published, the prevalence now is estimated to be in adults, and you heard Sue's work the other day, but the prevalence is about 104 to 110,000 cases, folks with suffering this in the United States. I think and as Dr. Oberg said, one of the most dramatic things I think has been there is a real increase in gastric carcinoids, and I think the PPIs are definitely involved in that. Also, rectal and ileal carcinoids, there's a percent increase in the worst ones that we experience, obviously the midgut ones, the ileal ones. So my bias is that I think they were there, but there probably are reasons now that we're seeing a real increase. But I think the histology now that we have stains, has allowed more diagnoses to be made, and we didn't have that really before the 1980s.
Dr. Sesky?
Well, I think we don't know, but about the first two comments, I must disagree with on one point. I think many people in this room take PPIs for any reason. I'm not aware of any convincing demonstration that in man, I say in man, PPIs are responsible for gastric carcinoids. They are indeed responsible for hyperplasia at the uppest grades of hyperplasia, but convincingly no dysplasia and no neoplasia have been reported with use of PPIs in man. So we cannot rule out this possibility, but I would seriously doubt that the use of PPIs is responsible for the increased incidence of tumors, and it could only be, of course, gastric carcinoids. So I'm not convinced with the available evidence.
I guess I'd like to make two comments. One is something that Tom said, that you have to listen very carefully to what Tom said and not make the mistake. And I get 100 inquiries a year about my doctor looked at my biopsy and called it a carcinoid, but how could it be a carcinoid because he didn't stain it with chromogranin? Chromogranin is not used to make the diagnosis. The diagnosis is made with the pathologist's eyes. The use of chromogranin informs the pathologist about the degree of differentiation as a confirmation. But the actual diagnosis, is this a breast cancer, a colon cancer, a carcinoid, or a lung cancer, is something that is pattern recognition that pathologists spend years and years and years learning the difference between what is a breast cancer and what's a liver cancer. And so it is not the stain that makes the diagnosis of carcinoid or not. It is the pathologist's ability to do pattern recognition. And the second question, or the comment that I'd make is about PPIs. I mean, the one thing that if you look at work done by a gentleman named Courtney Townsend, Courtney looks at gastrin as a growth factor and has shown that people with high gastrins have a higher incidence of colon cancer, et cetera. I have to agree that there is no conclusive data about the use of PPIs and the incidence of carcinoid. However, I think There is an overwhelming association that's developing, and in America, nobody does PPIs like the package insert says. The gastroenterologists routinely use it forever. And when patients, when they won't get it from their gastroenterologist, they go to CVS and they buy it. If you read the package insert, it says 12 weeks of use. That's it. And people ignore that, and that's what's getting people into trouble, I think.
We measure a lot of chromogranin in the lab, and recently I've looked back at about 1,000 chromogranin to see why they're raised. Is it always because of neuroendocrine tumours? Now, normally it circulates under 30. We see a huge number of patients raised above 100. But in the patients raised over 1,000, we expect that to be a tumour, and we find occasionally that is with patients on PPIs. Now, PPIs are given to cure duodenal ulcers, but they're also given for other reasons and occasionally given long-term because of reflux at the upper end of the stomach and in Barrett's esophagus. So PPIs can be given long-term. When these patients that have chromogranin A stimulated to this level of over 1,000, which is really high, come off the PPIs, it takes 6 weeks for it to come back down to the normal range, and it does. And we've done this in a number of patients. So these cells in the stomach, the ECL cells that produce the chromogranin A, are being stimulated to a huge extent when patients remain on PPIs. The other worry is in the UK, not only does your doctor prescribe PPIs and tell you that to take a 6-week course and come off it, they can be bought over the counter. So that's quite difficult now.
Can I just make another comment? And it is quite recently demonstrated when you're talking about chromogranin A that the N-terminal part of chromogranin A molecule, the vasostatin part, is actually a growth factor. And it's promoting angiogenesis.
A question now on carcinoid tumulets. Some literature I've read says that the presence of tumulets can mean a poor prognosis. Would any of the panel like to make a comment about that? So carcinoid tumulets in the lung.
Carcinoid tumulets in the lung?
Yes.
Yes.
There is an entity known as DeepNet, diffuse idiopathic neuroendocrine cell hyperplasia, where all through the lung you have an increase in neuroendocrine cells which are not malignant, but which proliferate and grow through the lung. It's a strange disease. Nobody understands really what causes it, although it's been associated with several kinds of infectious and inflammatory conditions which conceivably could have been some inciting factor. But in any case, when you have such a situation, you can develop so-called tumorlets, little teeny-weeny collections of cells in the lung, which gradually can increase in size and form tumors, and occasionally form carcinoids that can be multifocal and can be scattered all through the lung. In addition, these neuroendocrine cells growing in the lung can cause impairment in breathing, cause a chronic cough, which is usually not productive of any sputum, but just a cough and shortness of breath. And in a few really severe cases has led to a condition called bronchiolitis obliterans, which makes it so that you can't breathe and has even led to lung transplant. But I think that in general, when people have this condition, they just have to be aware that having radical surgery and cutting out carcinoids is not a good thing to do, because you're not going to cure the problem. You're only going to lose lung, and you're continuing to make more and more and more carcinoids. So one of the situations which I have seen before is people showing up with one lung, and the remaining one lung has 6 carcinoids, 150 tumorlets, and scattered neuroendocrine cells all over, and nothing has really been accomplished by that pneumonectomy that the surgeon did 3 years before, planning to go back and cut out some more tumors on the other side. So I think that the therapy of this condition is still has never been fully established, but I think that the use of a somatostatin analog to try to control growth of neuroendocrine cells is not unreasonable, although again, it's not something where there are large studies. I think that many of us in the neuroendocrine community are doing exactly this, and I know Dr. Warner has considerable experience with this, and other people do, using somatostatin analogs, and it seems to be helpful. But I think that it's an unusual condition. Thank you.
Okay. Here's a general question, and I'm not certain how we'd be able to answer this, but how soon can we hope to see benefit from the new drugs and therapies to become available to us?
I think that it's sort of like a question that we all face, whether it's an existing drug or an experimental drug. Most people rescan patients at intervals, do their markers at intervals, and make a decision about whether people are responsive at somewhere between 3 months and probably 6 months for most neuroendocrine tumors. How often, how long after starting somebody on a new therapy do you wait to restage them?
I think it's more of a question of a new drug comes down the pipeline. It looks very good. How long is it before the real world patients get it outside of a clinical trial setting? That's how I interpreted the question.
Oh, I'm sorry. I was swinging a miss.
Okay. That is this is a tricky question because, it's depending on the trials that are ongoing and if they are really showing the benefit you are expecting, that's one thing. The other thing is that the medical companies, the authorities also have a very long periods until they approve the drugs. So there is a combination, but usually when you start phase 1, phase 2 trials, it takes about 4 or 5 years until you have the drug generally available, at least in Europe.
I can speak. It's for want of a better word, it's sometimes how sexy the drug is, and is there something otherwise available. So a Me Too drug may take a long time to get through regulatory. However, the classic example of a drug going extremely quickly was imatinib mesylate for GIST tumors, a sarcoma of the GI tract where no therapy was available. So from the first publication in 2000 or 2001, the drug was approved in 2 years, which for those of you who follow new drug development is incredibly fast. But everything came together. A brand new drug, a cancer with no treatment, active patient participation in clinical studies, and the regulatory agencies all on board. And I've never seen a drug get approved that fast. Sorry.
Well, and I think the other thing is, and I hate to say this, but it's absolutely true, it goes with the sexy comment. Drug companies have radars, and if that drug and its projected sales doesn't match the radar of the company, it falls off the radar. Good example, yttrium-90 octreotide, originally brought into clinical trials by Novartis, had some patients who had superb results, but as they looked at the sales figures that they were projecting, it fell off the radar screen, and they ended up selling it to MIP because it no longer matched their corporate profile. So some drugs, even though they're very active and they fill a real need, they just don't think they're going to get their investment back, and so it doesn't make sense.
Just one other comment that since carcinoid tumors, neuroendocrine tumors are malignant, they are cancer, many of the same drugs that work for these tumors can work for other types of tumors. Yeah. And I think that because of that, the common tumors being more common have studies that are done with larger numbers of patients more quickly, and that has led to the approval of drugs much more quickly for those particular items that are active in other diseases. I think one that's coming up in the pipeline is the mTOR inhibitor, RAD-001, everolimus. So that's not approved yet. It's still investigational both for neuroendocrine tumors and for non-neuroendocrine tumors, but it's turned out to be one of the most active drugs ever discovered for kidney cancer.
Yeah.
And because of that discovery, it's probably going to be approved much, much sooner than it would have been if it had to rely only on trials of carcinoid neuroendocrine tumors. I think the drugs that are most difficult to get approved quickly are ones that are unique to neuroendocrine tumor the population, because there it takes a longer time to do the convincing studies.
The patient participation and advocacy is very important. In the GIST perspective, that's a rare, very rare cancer. And yet we managed to complete the phase 3 trials in record time because they have a very active and, well, very proactive advocacy group who encourage people to go on the trials. And so for that tumor group, which is rarer than this, we've managed to get 3 or 4 drugs available for those patients. So patient advocacy is also very important so that we could push through the clinical trials, because a lot of people are waiting for those clinical trials before addressing the issue of licensing.
I would just make a comment in terms of numbers and octreotide. It came to the United States in 1989, and in Europe in 1988. It was approved for indication for carcinoid and for watery diarrhea syndrome of VIP. But in the United States, it was approved on 177, based on 177 patients treated by 60 different physicians within 2 years of it being given out on a compassionate basis in the United States. So I find that truly remarkable that there is that sensitivity, and as was brought up by the patient advocacy and the use in patients do drive the machine, and it's quite remarkable to me.
I can just add a comment that some of these drugs can be approved as an orphan drug, and that is a more rapid procedure for the authorities to accept it. And in Europe, we have a very nice organization, the EMEA, which is taking care of orphan drugs in small diseases.
Just one more comment. The information that the regulatory agencies like the United States Food and Drug Administration uses to approve the drugs is basically the results of large-scale clinical trials. So I think that one thing that's very important to remember is that whenever it's a reasonable thing to do and consistent with patients' best interest in medical care to participate in a trial, to by all means participate in a trial, because it's only by your participation not only will you have an opportunity to benefit from the drug, but it will allow it to be approved much more quickly to benefit the rest of the world. And so that's the first thing, just a plea to stay in close touch with the available clinical trials. The second thing is I think we really have to congratulate Novartis and Ipsen and some of the other pharmaceutical companies that have been instrumental in allowing their new drugs to be studied in clinical trials at multiple centers throughout the world, so that simultaneously patients in the United States, Canada, Europe, Asia, all over the world are being able to be treated with these new drugs and allow results to come so quickly that hundreds of patients can be treated in a short period of time. The data can be submitted more quickly to the FDA, and drug approval can occur much more quickly for promising agents.
For the Canadians, one of our Ian Mackey from Health Canada yesterday said that they'll approve things if there's evidence, and just from personal experience that's very true. The problem is the companies may not be prepared to supply it. If they're not, even if there's a Canadian branch of the company and the agent is from Europe or wherever, they may not be prepared to supply it. And that happened to us about 6-7 years ago, where we had a patient, and form was done, sent to the company, and they said no. Legally, they were not prepared to accept, the risk for selling it out of, their own country. So even though it's available, you may not be able to access it, even if the government's willing to, waive all the rules. If the company don't want to give it to you, well, they don't want to give it to you. The other thing is they may be may want to charge you for it, and the price may be too much. Not from the hospital point of view, but if it's not given, for example, under the Canada Health Act, a drug given in a hospital cannot be billed to the patient.
Yeah, and the other problem is we have a lamentable reputation for slow approval of new drugs. Canada is the slowest approval, I believe, in the developed world.
Exactly, but again, you can get stuff through special access,
Yeah.
but the problem is the company.
Who's going to pay for it?
Yeah.
Okay, we should go on because we have a limited time here. So another question, for patients with poor octreotide receptors, I presume relatively low but some uptake on the octreotide scan, can they get sensitized by taking octreotide acetate?
Gosh, Dr. Odorizio just left. He's the perfect guy. He's the guy who has touted upregulation of receptors by use of somatostatin analogs. He swears by it. He's an honest guy. He claims it happens. I've never seen it.
No, I can support his findings. So actually, we published a paper almost 10 years ago that pre-treatment before octreoscan and after octreoscan, we could demonstrate that you had an increased accumulation. And
That's not, I don't think, what they ask.
No.
They ask if somebody's negative
Or poor?
negative or poor, can
Yeah.
long-term treatment...
Yeah, but let me continue. The next thing is that we have demonstrated clearly that if you treat the patient with alpha interferon, you upregulate receptor subtype 2 in the patient. So we have been able to treat a patient that were almost negative on octreoscan with lutetium-177 after giving him 6 months of treatment with alpha interferon, then had a grade 3, grade 4 uptake, and he was treated quite successfully.
Okay, this is as in the United States, they say, like trying to nail Jell-O to the wall. That wasn't the question. Interferon wasn't the question. The question is can somebody who has poor receptors for somatostatin receptor subtype 2 have long-term upregulation of the receptors by chronic octreotide use?
Yes.
I agree with you about interferon, totally. I think interferon causes differentiation of tumors and changes the receptor content. I want to know, and this person, whoever it is, wants to know about chronic octreotide use, taking somebody from negative or really P-poor to really good.
Actually, if the patient is almost negative in terms of somatostatin receptors type 2, it's very hard to upregulate it by giving him a somatostatin analog. I totally agree with you. But
Thank you.
I think we should have an octagon Ultimate UFC fight here. This
We
is
have
great.
had a few patients with medullary cancer of the thyroid, which is another neuroendocrine tumor, don't normally have a very high level of somatostatin receptor, and so they'll have a positive octreoscan, but lowly positive. And we have treated a number of these patients long term, and they have done surprisingly well. It's not terribly scientific; it's rather anecdotal, but they also have increased the somatostatin density on the scans as they progress for years, and a number of them have continued for many years with quite extensive disease.
I just would like to confirm from our quantitative data with gallium-68 DOTA-NOC receptor PET-CT what Dr. Oberg said. It's absolutely correct. In many cases, we're starting treating patients with very slow progression or no progression on sandostatin. And then we do an initial PET scan, and we do repeat it after 6 months, 12 months under sandostatin. And there definitely is in some patients an upregulation of receptors. You can measure it. It's very difficult to see on the octreoscan because it's done in different techniques, different institutes, different readings, different scales and so on. But if you measure SUV, you can really show there is an upregulation in patients with relatively low uptake. I have never seen a patient with no uptake becoming positive. So again, what you said is also true. You cannot convert someone from completely negative to positive, but there is definitely an upregulation in some cases if there are receptors.
We have several questions about familial tendencies of this disease. So what evidence is there of genetic transmission, I presume, familial transition of neuroendocrine tumors / carcinoids, and should screening of offspring be contemplated?
If we start with classical midgut carcinoids, I think there is a small proportion of families that this disease is familial. And Usually it's 1 or 2 or 3 members, so they're very small families. So that is not an issue of the screening. If you go to the bronchial carcinoids, they may be part of MEN1, multiple endocrine neoplasia type 1 syndrome, and that is also holds true for duodenal carcinoids and the gastric carcinoids as well as pancreatic tumors. So in families with multiple individuals that present this type of tumors, of course the screening program is recommended, and it's not a difficult thing. You can do this genetic screening quite easily in the members of the family. But for general mid-gut carcinoid tumor, I don't think that it's indicated.
In America, I just caution you, if you don't think your medical information is going to get stolen by somebody, just don't read the newspaper. I mean, the VA lost millions of patient records this year. I mean, it happens all the time. You can really screw blue and tattoo yourself and all of your siblings for 53,000 generations having the information about your genetic predisposition for a disease that can make you uninsurable. So if you're going to get that information done, pay for it in cash and submit it under the name, Alfred E. Newman. But do not do it under your own name and have it traceable back to your family, because you can make your family uninsurable. And if you think medical information is absolutely secure, no matter how much I tell you that my office is locked, there are a set of locked file cabinets and locked doors, and Hurricane Katrina comes in, and I can't get back to my office for 6 months. And when I get back to my office 6 months later, every file cabinet and every door is open, and you tell me how that happens.
I mean, those comments can apply to anybody with a family history of breast cancer or colon cancer. As soon as you see a medical geneticist, the legislation in Canada is very vague as to whether or not you have to report that to insurance. And I face this all the time with my young patients with HNPCC, with colon cancers, and should they be screened, because that makes their children automatically uninsurable for life insurance or critical insurance.
You can always use the name Barack Obama or John McCain, whoever you want, but just don't use your name.
Okay, a question about chemotherapy, which is what we don't use very often, but there has been some recent information about capecitabine, also known as Xeloda, and temozolomide, also known as Temodar or Temodal in Canada. Can you make comments about the effectiveness of these combinations? I know the phase 2 studies have been published and presented.
Yeah, we have performed one phase 2 studies, and there are also some other groups that have published on temozolomide alone or temozolomide in combination with capecitabine. And it's no doubt that this regimen is active in high proliferating tumors, and it's particularly useful when you have a high proliferation capacity, let's say about 25-30%, and you can see dramatic responses with complete clearance of metastatic disease. The thing is that the response rate is related to the expression of an enzyme, MGMT. So if you have a high concentration of MGMT in your tumor, then the efficacy is lower. So what we recommend during this type of treatment is just to screen for MGMT concentrations in the tumor specimens.
Is that an easy test?
It's not that difficult. You can.
That's mainly for the Temodal. That's its mechanism of action. What about for capecitabine? Does that also apply for capecitabine therapy?
No, this is for Temodal.
This is for Temodal, yes.
Then you can combine. You can give a 3-drug combination. You can give Temodal with capecitabine and Avastin or bevacizumab, and that is very effective also in high proliferating tumors.
And extremely expensive.
Dr. Warner and I just have a paper coming out where we took about, I think it's 70 well-differentiated mid-gut carcinoids and looked at them in drug resistance assays. And these are the ones that low proliferative rate that everybody has always said won't respond to chemotherapy, et cetera. And interestingly enough, the agents that came out in that testing, and it's going to come out in a paper in the Annals of Surgical Oncology in the next month or so, is Xeloda and Timidar, 5-FU Timidar.
Dr. Warner, would you like to add anything?
Just one more comment. I think this regimen is one that really should probably be utilized more widely than it currently is. Both of the drugs are oral. They're pills, generally well tolerated in the doses used in neuroendocrine tumors, and have the same kind of efficacy as much more toxic programs. And I think there are many situations where people are currently being treated with quite toxic intravenous chemotherapy programs based on cisplatin and other drugs, which are not necessarily more effective. And I think you have to realize that in a chronic disease with a long natural history and an effort to maintain not only length of life but quality of life, that there's a real advantage to using this type of oral medication. So I think that it's just something to think about seriously in many cases, and particularly in the well-differentiated low-grade neuroendocrine tumors where sometimes things that are much more toxic and intravenous don't necessarily have a higher response rate than this. In fact, they probably don't.
And the one other thing that I meant to say about Richard Mai's paper that came out is we've always assumed that cisplatin VP16 or etoposide was the regimen of choice for high proliferative indices tumors, and we were really surprised how many of those had extreme drug resistance to platinum etoposide. Thing that, so we weren't expecting the really well-differentiated to have low resistance and potentially efficacy, and we were expecting high sensitivity or very low resistance in the really aggressive atypicals, and we didn't see it.
From a Canadian perspective, these drugs are difficult to obtain. Depending on the province. In Manitoba, a have-not province, I could get these for my patients. In Alberta, who's awash in so much oil they don't know what the hell to do with it, you could not get these drugs unless the patients would pay, and it would be about $4,000 to $8,000 a month, this double combination. So even if they're available, patients may not be able to obtain them, and it's all depending on their provincial programs. Two questions about symptoms. Basically that they're not presenting with diarrhea, but they're having migraines, terrible headaches, and vomiting. So the question is this common not to have diarrhea, but to have other types of symptoms? Anyone want to touch that?
Well, I could say that not every symptom that happens in somebody who has a diagnosis of carcinoid has carcinoid syndrome causing the symptom. And I think if somebody has headaches, which were not previously present, that certainly cancer can metastasize to the skull bone, it can metastasize to brain, it can metastasize to other areas in the head. So I think that if somebody has a new onset of headaches and has a diagnosis of metastatic cancer, the first thing I would think about would be to get an MRI of the head with gadolinium and make sure that there's no metastatic disease anywhere in the brain, the bones of the skull, or other surrounding areas. Because if there is, that would need special treatment, and taking migraine headache medicine wouldn't help. If there's somebody with a history of migraine headaches, usually it's a chronic illness, and people have had headaches of that type on and off for many, many, many years, and even before the diagnosis of carcinoid, they know that they are migraine headache sufferers. Probably somewhere along the line would have already had other causes of headaches ruled out and are under treatment, and that's different. But it sounds like, from the nature of the question, that this is a new symptom that was coinciding with carcinoid, and I would really worry about that. I think
one thing that we've noticed is that if you have a brain met in the substance of your brain, it is extremely unusual not to have what's called a focal neurologic sign, and just to have headaches as a general comment. It's very rare that represents a brain met. It can happen, but it most of the time you have weakness on one side, you have a pupil that doesn't respond or whatever. The other thing, when you say the word vomiting to a person who evaluates people for carcinoid, especially midgut carcinoid, you always have to think of intermittent small bowel obstruction or narrowing of the gut, or as we were talking about yesterday, what they call intestinal ischemia or intestinal angina, if you have belly pain after you eat, an hour or two after you eat. So again, it may be carcinoid related, but it may not be due to the carcinoid as in the carcinoid syndrome.
I was just going to add to taking on board what my two colleagues have said. When you're living with a cancer for a long period of time, some people with midgut carcinoid are going to live for 25 years or more than that with the disease. It's really hard not to think that every time you feel under the weather, it's carcinoid related. That's just natural. So if you start to get migraines in mid-age, which lots of people do, then it's going to be carcinoid related. You shouldn't ignore these things, but if you take a bad cold in the winter, it's not lung secondaries necessarily. In fact, that's the bottom of the heap probably. And that's really difficult to live with a cancer for very many years and accept that there will be other things. You will develop other pathologies. In fact, you may die very likely of something else entirely. So there has to be a balance in your mind, and that's really difficult. But you shouldn't neglect symptoms either, but keep in mind that there's lots of other things. Everybody gets migraine. Well, not everybody, but many people. Lots of people get chest colds in the winter, and they don't have carcinoid.
Okay, so I think we've got only about 10 minutes left. What is the status of the generic form of sandostatin? Does anyone know?
Sandostatin aqueous is generic in the United States. There are two different companies that make
LAR.
it. LAR, it's years left on patent. I don't think Bruce is still here. I didn't see him earlier this morning. How many?
1 year.
1 year left on the LAR patent. So that means that you'll start seeing. And I was talking to the Novartis folks. I mean, they're already working on drugs that will come on next. Somatuline is already here. It's been around in nearly or longer, I believe, the depot form of lanreotide. So, there will be generics coming, but it's going to take a little while.
I can tell you that there are several companies working on generics just now, both in Italy, in Sweden, and also in India. And in Sweden, they are making a new formulation of octreotide LAR that can be given subcutaneous instead of intramuscular. So there will be a strong competition in the near future.
Will that drive down the cost?
Competition. Dr. Worthington, if you already have a gastronoma and you take a PPI, does this promote the growth of current metastases?
No.
Okay, well, that's very quick. Okay, a question about carcinoid heart disease. The two markers, ANH and BNP, are used for screening of carcinoid heart disease. Is one more better than the other, or are they complementary in screening?
You mean BNP or ANP?
Yeah, sorry, ANP.
Yeah.
They actually talked about BMP also.
Yeah. Actually, we were using ANP for several years, but nowadays we are using BNP, which is a more sensitive marker for heart incompensation. So I think BNP is a good screening marker.
And a supplementary question from another patient who had mild regurg in the tricuspid valve, it appears, and had an ANF, an AMP twice normal, an echo every year. It looks okay. Anything else that should be done? Or just continue with the yearly echocardiograms?
Yes.
Yes, okay. So the answer to the question is just continue with the yearly echocardiograms.
And do everything you can to keep your serotonin and your symptomatology well controlled.
Yeah. Why the decrease in effectiveness of sandostatin therapy?
That's obviously Guido, wherever he is preparing the assassin's gun to shoot me here. But I think that we offered in our paper 5 potential reasons why or octreotide blood levels could go down in patients who are on long-term LAR. One could be, we've talked about it, administration, that as people get better, they gain weight and they gain more fat, so they stop getting injections in their muscle and they start getting it in their fat, and their blood levels go down. Two, you can develop antibodies. If you want to build an antibody in a rabbit for a blood test, the way you do that is you put a peptide, and every month you give that peptide in something called Freund's complete adjuvant. It looks like the world, just exactly like LAR. And so there have been documented cases that people develop antibodies to octreotide. What makes us think that that's not it is if you switch from LAR to sub-Q by pump, your blood levels pop right back up. So if it was an antibody eating up the octreotide like Pac-Man, that wouldn't be the case. The other thing could be that the drug has changed over time. Novartis claims that they have not altered the drug. They claim that they have done a lot of due diligence and that they have, using the technology that they apply to the drug batch-to-batch variations, that the drug today is the same as the drug was a long time ago. So the answer is we don't know, but we do know that now with hundreds of people that we've measured blood levels on, that the blood levels today are exactly half of what they were prior to 2005.
A final question, and some of the questions that you may have written down have not been discussed in this one, but we've just gone through the rest of them, and Dr. Reed will discuss them. There's only about 3 or 4 left. The final question we want to discuss is, please explain whether a primary tumor in the pancreas which secretes serotonin is A, a carcinoid, or B, a pancreatic net. They seem to be discussed as being mutually exclusive.
These cases with pancreatic serotonin-producing tumors are rare, but there is publication of about 150 cases altogether worldwide, so they are not that uncommon. But of course, this is an endocrine pancreatic tumor, should be considered as an endocrine pancreatic tumor and looked upon it with respect to treatment. So my perspective is that this is not different from a lipoma or a glucagonoma of the pancreas.
Dr. Reed wanted me to be controversial, so I will. Dr. Elberg is obviously from Europe, and I'm obviously from the United States. There is a huge divide that I hope you picked up on between the European pathologists, how they classify these tumors, and how the American tumor or pathologists. In the WHO classification, if you have a well-differentiated neuroendocrine tumor of the pancreas, whether it measures insulin or secretes insulin or it secretes serotonin, doesn't make a difference. So in America, I think what the American pathologists are trying to do is to take the European system, i.e. we have a well-differentiated or a moderately well-differentiated or a poorly differentiated neuroendocrine tumor of the pancreas, and say if it secretes insulin, it's 95% chance that it's benign. If it secretes glucagon, it has a 95% chance of being malignant. So none of these classification schemes make everybody happy. And they don't help us classify every single tumor. They help us classify the average tumor, not the exceptions.
Actually, the take-home message from me is that this tumor, serotonin-producing tumor in the pancreas, should not be looked as a classical mid-gut carcinoid, although it's producing serotonin. It should be included in a group of endocrine pancreatic tumors, and of course, usually they are malignant, most of these, except for benign insulin-producing tumors.
Just one additional take-home message, that even though this is classified as a pancreatic neuroendocrine tumor and everything that has been said, I fully agree with, nevertheless, the bottom line is this tumor does make serotonin like carcinoid tumors that arise in the gut, and very often will metastasize to liver, cause carcinoid syndrome, and clinically look indistinguishable from carcinoid tumors of other types. And I think that everything that you know about management of carcinoid syndrome, preventing or treating carcinoid heart disease, and dealing with flushing and diarrhea are all exactly the same as a carcinoid that arose in the gut. So from a pathology point of view and a diagnostic and classification point of view, this is a pancreatic neuroendocrine tumor and not a carcinoid, in quotes. I think from a treatment perspective, it's very, very similar when it metastasizes to treating a carcinoid tumor that arose in the gut.
But I also want to say that looking into these 150 cases or so that have been published over the years, very few actually presented the carcinoid syndrome. So the production and secretion of serotonin is mainly found during histopathology.
Well, I'd like to bring this first part of the session to a close and thank the patients for their very probing questions and for the panel for their insightful answers. I'm going to hand this over to Dr. Reed, and I wish everyone a safe journey home. Thank you.
Thank you. I'd just like to add my thanks to everybody for coming, and especially on a Sunday morning when they've got to be at the airport by 12 noon.